covered the field quite well, and I'm going to basically corroborate what he's going to say, but let me just give you this example here. What do you think, what would you do with this left main lesion that you can see up here? You see that 1929, you probably say patient's too old for bypass surgery anyhow, so go for PCI. But this is a case of 1977. So at that time, the patient was just 48 years of age. And of course, angioplasty was just born. This was case number 2 of coronary angioplasty. And you see, it was a left main case. And at the time, of course, this was thought to be the best indication because the catheter was not steerable. So the Grünzig was sure that he would get to this lesion because it was right there at the orifice. So this is what was done without any hesitation. Okay, the balloon was inflated, and this was the result. Looked pretty good. But of course, there were no stents, so it was November 11, 1977. And this was a 2 months follow-up, an elective follow-up that looked pretty good. It's, of course, not like a stent result, but this is what you got after balloon angioplasty. So if you look at the history, case 2 and 4 of worldwide coronary angioplasty cases were left main stem. So it was there from the beginning. Now, why did it disappear for some time? Actually, for all the wrong reasons. Because of the 4 left mains that were done in the initial phase, 2 died within 6 months. And this was just a bad coincidence because none of the 2 had a left main occlusion. They died of arrhythmia or something that was actually unclear. But of course, then they said, well, 50% mortality, left main PCI, it's not acceptable. Do not do left main PCI. I'm pretty sure that if they had done 1,000 left mains, they would have found out even then that the results were acceptable. Those 2 mortalities, which were not due to left main occlusion, but to some other reasons, actually killed or at least hibernated left main angioplasty for quite some time. Now, we all know that 5 patients with angina will have a left, percent of patients will have a left main stenosis. We know that the mortality is really poor. It's a very dangerous disease, almost like cancer. And of course, we know that CABG, and they have shown that now in many slides, improve survival. So we have to do equally well if we want to be competitive. Now these are the indications where everybody will probably agree that you can do it. It's a protected left main coronary artery. If it's protected, I think PCI is rather safe. And this can be due to the fact that there are already bypasses placed from prior operations or collaterals from the right coronary artery. Or you have you don't really have a left main, you have a circumflex and LAD separately, so there is actually no left main stenosis. Now here is such a case, again a rather old case, but it can still of course serve a purpose. You see the right coronary artery is also diseased, but you see several collaterals filling quite nicely the LAD completely, so you're really not worried that if the LAD, if the left main angioplasty goes sour, that the patient will crash because he's already living on his right coronary artery as it is. So you can certainly, at the time, of course, nobody would do both sides during the same session. Nowadays, you'll probably even do both sides. Now, of course, if you have an inviting lesion, which is not too complex, plus I would say at the most 2 additional lesions. If you really have complex multivessel disease plus left main, I agree that surgery is the way to go, and myself would certainly go for a good surgeon rather than having angioplasty. This is about the upper limit of what you can do with angioplasty. You see the left main plus a pretty long complex circumflex lesion. This is probably still acceptable, but it's about the top of the line where you should try PCI. Actually, our indications, of those going back to the initial times of angioplasty for all angioplasties haven't really changed much. We've always have done some multivessel disease if it was easy, but complex multivessel disease, and this has been proved time and time again now with all the randomized trials, is still a realm of surgery. Now, of course, there are some situations like acute left main occlusion that the patient comes in shock. I think PCI is better than surgery because it's faster if the cardiogenic shock is already there. Very old and inoperable patients, you have no other choice. Extensive prior infarction, so if the actually left main territory is already gone, I think left main angioplasty is okay, even if it's not protected. Patient lives on a large right. And of course, if you dissect the left main, you've seen some cases this morning. One went to surgery where his life was saved. But of course, if we can do this right in the cath lab, you first of all feel better because you caused the problem and you fixed the problem. And second, it might be quicker than emergency surgery. Here, of course, now the data, and most of them have already been summarized by David. You can see here deaths versus BMS. There is now no more doubt. There was some unjustified doubt whether death is good for left main. It is much better. If you look at the different things like mortality, and everything below 1 means that death is better than BMS. And you can see that in all the studies it was better, even 50% reduction of mortality, infarction rate is improved, and of course TVR, which is actually the main virtue of death over BMS to prevent restenosis, is dramatically improved. And if you take all together, there is no doubt that if you work in the left main, you have to use DES. Now, of course, comparing these DES to bypass surgery, and this has also been shown by David already, you can see that looking at all the events put together, you can see that there is actually a draw, but of course these cases were selected. That was not all comers. These cases were selected. Some even showed some advantage of PCI or tendency to, but of course they were even more selective with their cases in their trial. Some cases it was more going to the other side, but overall there is no real difference, be that 1, 2, or 3 years of follow-up. Now if you're looking at mortality, again the same thing at 1, 2, or 3 years of follow-up. There is no difference between CABG and PCI, which was DES PCI, but of course mostly using the older first generations of DES. But of course those patients were pre-selected. That was not all comers. Now looking again at another depiction of it, you first look at mortality, again looking at all the different trials, and here the syntax trial is already included. You can see that in some even there seems to be a trend of better mortality figures with PCI, but again this must be due to selection of the easier cases. If you look at myocardial infarction, there is no difference, and if you're looking at stroke, this time it goes clearly to the side of PCI. So surgery does have a higher risk of perioperative stroke than PCI. That's something that, of course, is not a fault. It's not due to the surgeons, but it's just a bigger intervention. And of course, the comfort, which is not on this slide, will of course be heavily biased towards in favor of PCI. It's much less uncomfortable to undergo PCI than to undergo bypass surgery, that's for sure. But on the other hand, of course, the need for a second intervention, later surgery or repeat surgery or another PCI is significantly higher with PCI because of the complete revascularization thing, restenosis thing that surgeons have much less a problem with than PCI operators. And now, of course, the new and the old tests, it is, we all know that the current tests are really much improved over the old tests, in particular that their bane of the risk of late stent occlusion after the first year has almost disappeared. So nowadays, and you probably won't realize that if you would not use any antiplatelet agent in any stent patient, your stent thrombosis rate with modern stents would be somewhere between 2 and 3%. which means that you're giving all your antiplatelets to 97 out of 100 for nothing. But of course, you don't know who's going to need it, so you better give it. And 2 or 3% of stent thrombosis is still bad, but it's not so that everybody without antiplatelet goes down, and with antiplatelets you don't go down. So modern stents are not very thrombogenic. And you can see here that in this study, the ISA trial of Adnan Castrati from Munich, lumped together, you can see that the stent thrombosis rate in left main cases, left main PCI, has been halved by just the modern drug-eluting stents compared to the old drug-eluting stents. And David Taggart has shown that also, and I just reiterate that you have to make some distinction of the the initial situation of the patient. You can see that isolated left main stenosis, again, it's not all comers, it's again selected ones, but if it's isolated, PCI seems to be very competitive to CABG. David has admitted to that, as all the surgeons nowadays do. PCI plus one vessel seems to be also okay, although there is a caveat that I'll come to in a moment. If you have 2 additional vessels, it starts to really be worse than surgery, and of course the overall risk increases much more with PCI if it gets more complex than with surgery, as you can see here. And if you have left main plus triple vessel disease, surgery is really the way to go, as we all know. Now this is actually one of the advocates of left main coronary angioplasty, Park, who shows the same thing in his group, and we've seen that slide before, that there is really no difference in death, myocardial infarction, and stroke with surgery or bypass or PCI, with the exception if the RCA also needs PCI. Even the Pope of left main PCI nowadays, Park, will argue that CABG may be the better choice. I wouldn't go that far to say every right coronary artery lesion excludes a patient from PCI if there is a left main stenosis, but certainly treating the other vessel is dangerous. If you just do an additional circumflex, it's already in the risk of the left main, but the right coronary artery adds another risk. And of course, if you look at the revascularization risk, of course, surgery is doing better than PCI because it has a more complete, more definitive type of revascularization. And here, going back again to the syntax study, the 3 years follow-up, you can see the same thing. If you take all left main, it looks like CABG is slightly better, but not significantly so. If you take only isolated left main, actually in these still selected but pretty broadly included patients. For instance, in Bern, we never participated in the syntax trial because when I saw the protocol, I said I would never do PCI on the patients that are included here for randomization, so I'm not going to participate because I would be forced to do PCI on patients I would never do in real life, so I will not participate. And this turned out to be true. The high-risk part, which I refused to take part with, actually turned out to be a bad choice. So, and you can see, but even in these, broadly included patients, you can see that left main isolated PCI is really competitive, not better, but competitive. And again, the same thing, it changes somewhere. If you add 2 vessels, surgery is better, and of course, if you add 3 vessels, surgery is better. And here you can see again the same thing as David showed at the syntax core. A lower syntax core, you can see that PCI might even look a little better than a surgery here. But clearly, if you have a high syntax core, CABG is the way to go. Now let me just go again to my frugal approach, and this is again a case that dates back a little bit, but I would still do the same. That was maybe it's about 10 years old, and I started 20 years ago to do this simple approach, or even over 20 years ago. Here you see this is a pretty complex left main lesion where you might already have your doubts if it is good for a PCI. It's 75-year-old man with angina. And this was a 4 French diagnostic study showing the lesion here. But this patient again had excellent collaterals. You can see the entire LAD and you can see the entire circumflex lighting up when you inject the right coronary artery, which also has a proximal lesion, but excellent collaterals to the LAD and to the circumflex. So there is no doubt that you can do this left main quite safely with PCI, although it's a bit intricate. This is again the left ventricle, which is normal. And so the first thing was a stent that was put in the LAD, and again my washout collaterometry, as you can see here, the balloon is now inflated. There was dye in the LAD and the circumflex before, but it's all gone after a few seconds, and you'll see this now in flow. You see inject and at the same time inflate your balloon in the left main here into the LAD, and immediately the dye disappears on both sides. So this, of course, we already knew in this case that there were collaterals, but this just proves it again. Within 10 seconds, all the vessels are gone because the right coronary artery provides so much flow. Again, inflating the balloon while you inject. Now you see you're blocking the left main, but the distal vessels disappear almost immediately and showing the perfect collateral. So this left main going down, the patient wouldn't even feel it. Of course, during exercise, he would feel that there is no more left main. Now this is the result after putting a stent in the LAD and dilating just the circumflex. So it was just a provisional, stenting of the LAD, but no stent in the circumflex. And then turn to the right again, and you see that the collaterals have disappeared, showing you a good pathophysiological result. Now, nowadays, with the drug-eluting stents, I would certainly do the right during the same session. Then we didn't have those good drug-eluting stents yet, so I called the patient in after 8 months for a second session, again doing the left ventriculogram, this time taking the left amplats right away because I knew I was going to dilate the right coronary artery. So that's a sheathless femoral left amplats catheter. You can also introduce it radial, of course, if you want. And a normal ventricle first with this catheter, then you put it in the left main. You see a pretty good result 8 months later, so it's past the time period where restenosis can occur, and in another view you see that the result even in the non-stented circumflex looks pretty good. And of course injecting the right now, the lesion is still there, but there are no collaterals. They have not reappeared. They do not need to reappear, but they would be there if the left main did go down. And so there was a stent put in now in the right coronary artery with this result. Thank you very much.